Thank you, Venkatesh. At the outset, I thank Venkatesh for inviting me to be part of this wonderful symposium, instruction course on a very important topic. My topic will be limited to myopic CNVM. Nothing to declare as far as financial disclosures goes. I would like to present a case which came to us very recently. 35-year-old male, one-eyed patient, other eye having been lost due to RD. He was enjoying good vision, but he came with a 2-day history of drop in vision. And we see a small hemorrhage in the foveal region, and OCT clearly shows the same thing, and there are some RP changes next to the hemorrhage. Being a one-eyed patient with a recent drop in vision, patient was also very anxious, and we were also keen to rule out CNVM. FFA shows a block fluorescence and a leaking spot next to the block fluorescence suggestive of a CNVM. So this is not an uncommon way that patients with myopic CNVM present to us. So myopia in CNVM occurs in about 5 to 10% of the myopic patients. It is a common cause of loss of vision. In fact, among all the various degenerative changes that occur in myopic macula, I would say CNVM is perhaps most easily treatable at present, and therefore it is important that we diagnose this as early as possible. Let me take you through another case. 25-year-old female. She was on regular follow-up. She came with a drop in vision from 612 to 636 due to this hemorrhage here in the macular region that you can see on OCT. We did a fluorescein angiogram. It showed blocked fluorescence due to the hemorrhage, but no CNVM. Patient was observed and vision returned to its original level of 612 over 1 month period. We were all happy. 6 months later, same patient presents with metamorphopsia and drop in vision of one line. There is no hemorrhage now, but there is a CNVM, which was confirmed on fluorescein angiogram to be present. The questions that this patient threw up in my mind were, could the CNVM, which is evident now 6 months later, be hidden under the hemorrhage, which was somewhat large than the first patient which I presented? Another question which came to my mind is, in a myopic CNVM, myopic hemorrhage when the patient presents, should we wait for the hemorrhage to clear and then order a fluorescein angiogram? But in patient number 1 which I presented, you saw that we could pick up the CNVM even when the patient presented with a hemorrhage. So should we make a distinction between a small versus large hemorrhage? If it's a small hemorrhage, you could go ahead and do a fluorescein. If the hemorrhage is slightly larger, maybe you should wait for the hemorrhage to clear so that you can detect the CNVM, which otherwise would be hidden by the hemorrhage. But these are some of the questions which came to my mind, and unfortunately we don't have answers to these by the available literature at present. So how is myopic CNVM different from the AMD CNVM, which we are more commonly seeing and treating? These are small. They are of the classic variety. You never see an occult CNVM. Hemorrhage may be present, but important thing is these CNVMs do not leak fluid, unlike AMD CNVM. So therefore you won't see retinal serous detachment, you won't see retinal edema, you won't see cystoid changes, and you will not see hard exudates, which are all part and parcel of an AMD CNVM, wet AMD. So these will be missing in the myopic CNVM, and therefore OCT does show the CNVM, but does not show real intraretinal changes that we are accustomed to seeing in AMD CNVM. So therefore I always do an angiogram to detect the CNVM. Now we need to have a high index of suspicion whenever we see any myopic patient with either complaints of metamorphopsia or a recent drop in vision. You must suspect CNVM. Now, as Venkatesh and other speakers, Vindu, showed many lesions in the macular area, sometimes it is very difficult to pick up CNVM clinically, and even on OCT and even on FFA. Look at this fluorescein angiogram done on one of our patients. He is a one-eyed patient who again presented with recent drop in vision. The macula has so many atrophic patches with In the late phases, the edges of the atrophic patches showing hyperfluorescence, the patch themselves become hyperfluorescent. So in this whole thing, it is so difficult to make out where is the CNVM. Often we are confronted with patients like this in whom we are finding it difficult to identify CNVM. So we need to study these eyes very, very carefully in the fluorescein angiogram, comparing the early, mid and the late phases. If you look carefully, this edge of the atrophic area here is showing a hyperfluorescence which begins in the mid phase, and that probably is the site of CNVM, which again we confirmed by doing an OCT along this line scan, and the patient was subsequently treated. So these are some of the challenges which we face in the diagnosis of CNVM in myopic patients. Now once we have diagnosed this, management, laser was what we used earlier before the PDT anti-VEGF era. Of course, it can only be limited to the extrafoveal and maybe the juxtafoveal. But since most of the myopic CNVMs are either subfoveal or juxtafoveal, laser treatment is not an option for most of our patients. When the PDT came, we thought it could give a solution for myopic CNVMs also, as it did for the wet AMD. The VIP 1-year study did show that the treated group did better than the control group in terms of vision loss being avoided, but the 2-year results of VIP clearly showed that control group and the treated group did not fare much differently in terms of loss of vision. So PDT failed to establish any benefit in pathological myopia in the long term. Short term, it did seem to help. So, but with the anti-VEGF therapy, definitely there is hope, and we have seen that anti-VEGF therapy works in CNVM due to myopia, just like it does in CNVM due to other etiologies. So when I was preparing for this talk, I was looking at various reports of literature. There are plenty of literature available about the treatment of myopic CNVM with anti-VEGF therapy. There are many studies and reports. Most of them are non-comparative, non-randomized, non-controlled trials, case series, short-term, long-term. They have shown that anti-VEGF therapy benefits in CNVM myopia. We just did an analysis of our patients with a more than 1-year follow-up myopic CNVM. We had 14 patients, average follow-up 17, average age was around 50 years. In all the patients, vision improved from 0.9 to average vision improvement was 0.9 to 0.6. In about 84% of patients, we were able to stabilize or improve the vision with an average of 4 injections per eye. This is just to show how the OCT is not really going to show you much change from the first pre-injection to the last injection, after the third injection. You see that there are minimal intraretinal changes, there's no fluid. So OCT is not a very useful guide for you to decide about how the patient is improving, how the patient should be treated, whether he needs a retreatment. OCT is not, I have not found it very useful in the management of myopic CNVM, though it's useful in the diagnosis. Again, look at the changes in the OCT. Patient did improve, patient is stable, but OCT is not really helping you much in deciding about the regression and need for retreatment. Recurrences are not uncommon. 47-year-old male, this is a juxtafoveal large CNVM that you can see here. Patient is maintaining good vision. On fluorescein, we confirmed, and then we treated the patient with 3 injections of Avastin. FF was also repeated. It showed a scar CNVM. We thought everything was fine. But 2 months later, to my great surprise, patient present again with drop in vision, and the CNVM has grown, and we had to retreat him with more injections of Avastin. So even in myopic CNVMs, you have to keep a careful follow-up. It's not that all of them do regress and maintain that way. Questions which remain unanswered today are whether we should use Avastin or Lucentis. Is any one superior to the other? What's the regimen that we need to use? Do we need to use a loading dose or a PRN dosing? And how to follow up these patients? Some of the answers are found in this study which came out in October 2013. This was a systematic review and meta-analysis of anti-VEGF treatment for pathological myopia. The authors have done a good job in looking at 18 comparative and 83 non-comparative studies of published literature on anti-VEGF treatment in myopia. What did they find? They found that anti-VEGF therapy is superior to PDT. they found that the 3 loading dose with PRN follow-up and treatment is slightly better than single injection followed by PRN treatment. They also found that the results are same whether you use Avastin or Lucentis. So this study has given us some guidelines, some information as to how we can manage our patients. The latest study which has come out in January 2014 is the Radiant study. This was a randomized controlled study comparing ranibizumab with PDT for myopic CNVMs. They had 3 groups. 2 groups were using ranibizumab based either on vision stabilization or the disease activity. The 3rd group received PDT. And what did they find? Not surprisingly, they found that ranibizumab scored way over PDT in the management of pathological myopia. But ranibizumab groups have much better visual acuity compared to the PDT group. So today, in terms of managing myopic CNVMs, anti-VEGF treatment is the way to go. So, in conclusion, myopic CNVM is an important, common and treatable cause of vision loss in myopic patients. You need to keep a high index of suspicion because lesions are small, they are subtle, you may not be able to pick them up clinically. You may need FFA and OCT both to diagnose them as well as manage them. And today anti-VEGF therapy is the mainstay in terms of treatment. There is no evidence to say which is superior between Avastin and Lucentis. I think we all end up using Avastin or Lucentis based on the patient's affordability. And the treatment regimen is at present not standardized. Whether you want to use a 3 loading dose or a single injection followed by PRN, probably you follow your own regimen. Thank you.